The first one I want to ask Chris and Dot, because you're working with families that have experienced a lot of challenges, and just wondering, can you tell us what gives you hope? What we should keep in our minds when we're holding hope?
I think one of the most important pieces of sustaining hope and working with challenged families is that, first of all, our own team has to be resilient and vulnerable to one another. I think if you don't have a team and you work more and more and more alone, you're going to be overwhelmed by the experiences that you hear from the people you're serving. Another piece that I think certainly gives me hope on a daily basis is that we're working with really young children, and young children are, there is something in the heart of a young child that is still hunting for relationship and attachment, and to be able to participate in rebuilding those chains that reconnect people together it's very, very humbling and very hopeful. And I think that when we're able to reach children who are young, their parents, who often have worked with other agencies who may have shamed those parents, the prison systems, other places, when they enter the building and they see that their child is being cared for, their shame decreases and their attachment begins to shift. And there's a lot of hope in that interconnectedness.
From my perspective, I'm similar to Byron. I'm on the administrative side, and I spend a lot of time meeting and talking with our donors and supporters in the community. I would say that one source of hope for me is seeing their increased understanding of the importance of not only parent-child attachment, but supportive relationships throughout the community. And to see our donors and our supporters come to Jumping Mouse, have a look around, and really start to understand the model of what we're trying to do here, which is to increase that attachment and build stability, not only for the child, but for the parent, and how that ripples out into the whole community. To see them increase their understanding and step forward and give not only from their pocketbooks, but from their hearts toward our program is really inspiring. So that's one of the key places where I find hope in the work.
Thank you. Yeah, I think one of the most courageous stories I heard today was from Rita. And just, I'm so impressed when parents understand that they have the power to make their children's lives really great. That's an incredible, I think a lot of parents miss that. It goes by and they don't catch it. As young as a daughter of 5. So I wanted to thank you for talking about that and just ask, what gives you courage to speak to this group, but also in your daily life? You have to carry courage with you to make a change that you're making in your life.
What gives me courage? This may sound corny, but honestly, my daughter. I was always one, because of my childhood, I never really wanted children, never wanted to get married or anything like that. And then once I had her, she has become my entire world. And I feel very strongly about these kind of issues as well. And so just being here has been an honor. And I do see the ability for parents such as myself to really have a huge impact on their children. And so I'm hoping that she is young enough to where I can change this around so she doesn't have to have the experiences that I went through.
So that's Lacey, and I actually know that, and I apologize. I called you Rita. Rita, do you want to comment on from your perspective,
Yeah, I just, what gives me courage is the support of the people that I work with. So having a program director who's super hands-on, like I have, and is passing on this information and encouraging us to utilize it and giving us the tools to do so. And then having a super awesome coworker, Mary, who's here, who is like willing to jump right into this with me and just kind of see what we can do to help parents and kids have better futures. Is what gives me courage.
So many people in this room, you may or may not recognize that for most managers, we implement programs that were already developed. We're not taking basic science and infusing it into all of what we do. And bringing the ACE study into practice is a huge leap because we're not waiting for someone to develop all the programs. We're moving on this information now because it has so much potential for saving lives. And that's a really different kind of work. And I think, you know, Rita, you've mentioned some ways that it's changed in your organization. And Byron, you talked a little bit about the difference between implementing a program that somebody already made and trying to infuse basic science, neurobiology, epidemiology into your work and have those kind of ahas, I'll try this. So I was wondering, Byron, if you wanted to comment on sort of your personal journey of how you went from practice change and policy change.
Well, I've always kind of been interested in this kind of stuff, you know, the kind of development phase and management and how all that works together. It's like doing, things, people develop programs in institutions and then they throw them out into the community and expect you to replicate them with real people, with real situations, with real organizations, with real financial challenges. And so it's like, all right, we got to figure out how to make this work a little bit better. The bottom line, I think the starting place with this is really the values and principles that our organization has actually pulled together and made as a fundamental piece of our work. And we worked really hard on this, especially about 6 or 7 years ago when we started doing that. And the first thing that happened, or actually the first, we took a lesson out of the business community. You know, we all read Good to Great. And say, what do we do good? You know, what are we great at? And we instantly wanted to say, oh, we're great at preventing child abuse, you know, because that's our mission, to break the cycle of child abuse. But then we said, well, we really can't be great at that because there's too many other agencies and people involved. What can we be great in? And as this conversation happened, we said, we can be great. We can be the best at relationships. That drove everything that we started making happen. So Good to Great was a big part of that discussion, and out of that we started. We were actually having conversations. We have conversations, not training. We have conversations with amongst our staff in terms of how to develop. And out of those conversations, somebody said, "You know what we're trying to do is really like this business management book that I read not too long ago called When Fish Fly." You know, it's about the Pike Place Fish Market, and so okay, well, let's check that out. Let's look at those principles and what's going on in that area. And that seemed kind of fun, you know, because I like the fishmongers; they're pretty cool, you know. And so we looked and said, hey, this guy named Jim Berquist, you know, he kind of was a consultant for them. Why don't we give him a call? So we gave him a call, and we found out he lived in Fairhaven, right in Bellingham, you know, and so. We called him up, and he came over, and he's been consulting with us pro bono for the last 5 years. And so some of those business practices and principles that are there. So this is kind of part of what we do. We bring in these concepts, business concepts, you know, the advances, and anything that's cutting edge, we like to be a part of. And when there's not a program out there that addresses a particular issue that we have, we figure out and come up with a new one and do research. And so the whole research and development area around this field, we like being a part of that. And it kind of empowers us and makes us who we are.
And Chris, do you want to comment on that too? How you move from the idea of epidemiological study and moving it in? Either one of you?
Well, one thing I think I would say about Jumping Mouse is that from the founding, relationship has been at the core of the therapy model, and that from the very beginning, we've been asking these types of questions of our parents. What has the child experienced? What have you experienced? The fact that we now have this scientific research to back up the phenomenon that we were seeing among our population really allows us to have deeper and fuller conversations with the other agencies in our small community who are doing similar work or who are working in different sectors. An example would be that we got together recently for a brown bag conversation at the hospital. We had folks who were working in infant care, we had child mental health, we had geriatric care, we had an ICU nurse. Every person around the table was taking this information in their own way and applying it to the spirit of their work. And that, I think, has been and will continue to be one of the game changers for our organization and for Jefferson County as a whole. We also have a very active public health program, community network. The police department has had ACEs training. Many of these agencies are coming together, and we're using this language and this information in new ways to build partnerships that support each other and that support our clients.
I think the biggest strength would be knowledge, and really just our what's the word I'm looking for? Just like working as a group and having that support, having the support system of other parents that are going through the same thing, that may have similar backgrounds as children ourselves, and learning how to break the cycle is a huge thing. And they always say more power in numbers. I think that and just like I said, the general knowledge of the ACEs and the effects and how to prevent them any further.
Others? You want to comment on that? Thank you.
I'd like to comment on that because I think one of the things we get tied into with kind of breaking these patterns is that only the people that are referred to the agencies and referred to the programs that are out there or have state intervention, and as we know by ACEs, is that this isn't just, these aren't the only people. It's the broader community and that we need to address. And so I think we need to look at how do we shift norms in the broader community and getting people to understand their role in actually protecting kids and doing kind of that sort of thing. So we need to train and orient folks in the community, like using programs like Stewards of Children, Darkness to Light. It's like these are programs that we can go out and train folks and so that it becomes a norm to make sure that when a parent takes their child to a particular program or an agency or a sports club, that they say, "Can you tell me what your adult child safety policy is?" And this would be the standard way that we do this. Just like, we should be shifting how we're doing this work. Just like, and we should see this change in how we operate in terms of safety around our kids. Like it used to be two years ago, you could see people driving around with a cell phone, right? And everybody's doing that. Today, when you see that, you're going, no, that's not okay. So we want to have this as a community norm. I think we also need to make sure that all of our organizations that are dealing with kids actually have some sort of adult child safety policy in place. And I think those are kind of some systemic kinds of things that we can reach out into the community in an easy way.
Other comments?
One thing that we focus on at Jumping Mouse is how the child can become the catalyst for change in the family, because we are working with the very young. When the child starts to display well-being, resilience, self-esteem, courage, it's often a really great inspiration for the parents and brings hope to everybody who's involved. And that's, I think, one of the key factors that we focus on when we think about intergenerational health and change for the future.
I can speak to that for a minute too. So in our groups, one of the things that we really do focus on is building support within the group of parents. Just kind of like Lacey was saying, that's one of the most important things for helping break these cycles, these generational cycles. And in the Families in Recovery program, the focus is on parents sharing their stories, sharing their needs, and then getting feedback from each other with some guidance from the group facilitator, but really encouraging parents to own that and learn how to build their own communities of support around each other.
There's a couple questions on this card. One is, are there certain ACEs that have greater impact than others? I think that's one of the big findings from the ACE study, is that there aren't large statistical differences in the power of each individual ACE as you compare them with each other. It's the cumulative effect of many different kinds of experiences that seems to have the power. And from a neurobiology standpoint, I think that makes sense, because there are these different sensitive developmental periods, and it's very unlikely that a human being would have all 10 ACEs only in 1 month of their life, right? It's likely that when you have an accumulation of many kinds of ACEs, that has impacted multiple developmental stages. And so it makes sense that they would have a cumulative impact, also based on the reason that ACEs have impact is that when stress hormones and neurotransmitters are up in the body for long periods of time, particularly cortisol is actually toxic to brain cells. And so it changes not only what the life and death of brain cells, but also the myelination, the fatty layer that protects the electrical signaling from going. So I'm not sure that we're going to see further studies that say one is more important than the other, because the biological reasons for their cumulative impact really would support any kind of toxic stress that's either episodic or long-standing in a child's life having significant effects. I don't know if anybody else wants to comment on that from your perspective. You can. How do we identify children with ACEs before they enter social services? And I think this gets to Byron's point he was making, is that ideally, you know, the resilience literature would all the resilience researchers would agree that children do best in a nested, thriving environment, where they're in a thriving family and they're in a thriving school and neighborhood and they're in a thriving community. And until we're able to shift that whole set of nests, we're probably not going to be as effective as we'd like to be. And so this is a really important question of, you know, how are we identifying families that need help before they ever enter services? And I think several communities are working on
well,
that.
I mean, the thing is that what I always, it makes me angry is that we've got these evidence-based parenting programs that are like the best things you can ever, I mean, it's like the top of the line in terms of what we can train parents in, you know. I mean, the research shows that there's nothing better out there, but it's only available to those who actually have abused their kids. You know, is this crazy or what? So we've got to figure out how we can get this to happen. We were able to get Group Health to cover parent-child interaction therapy as a primary treatment option for kids that have externalized behavior problems. And I think the recognition that is really more important than maybe a 50-minute therapy session or something like that, that this is about family, it's a different way of doing that and getting the community to respond to that.
We have at least one example in Jefferson County in Port Townsend of a private family medicine clinic that is now asking the ACE questions of all expecting parents, mothers and fathers.
And there's good news in Washington State. The Healthcare Authority and the Department of Social and Health Services actually wrote into the new contracts for insurance payors that they need to do education about ACEs for primary care providers. So we should see more of that happening over time. And that relates to a question here that's about how are we thinking about protecting people so that their ACE scores aren't used against them in the insurance world. I think that's really an important question that all of us should be thinking about. And it's one reason that DSHS and the Healthcare Authority wrote in that the role was education, because any collection of ACE scores, I believe, should be held in the private confidential health records or other places, or not be turned in at all. I mean, I think we heard Lacey's story was her own understanding of how her ACEs had affected her was enough. Everybody else doesn't have to know. And it's also the beauty of talking about ACEs is I can say I have 5 ACEs, and you don't know which ones. So it actually can create more safety as opposed to more danger. But I do think we do need to think about it. We have, what resistance are you encountering to the science of ACEs? Have you encountered resistance to it?
So when we first started talking about ACEs in our groups, some of the parents felt like this is just making us feel really hopeless. Like we're looking at this and feeling like, oh great, now not only am I like having these issues with my kids, but I'm gonna have heart disease and all this stuff. And so what we found after our first discussion is really taking a step back from that and focusing less on the adverse effects of adverse childhood experiences and moving forward to talking about prevention has helped lower those walls a little bit and helped parents really start talking more about what's going on with them without, reenacting the trauma or bringing those feelings of hopelessness, because that's, not going to help anybody. So.
Yeah, I think 10 years ago there was more resistance in Washington. There isn't really a lot of resistance now. There's mostly interest, and people is big systems trying to figure out what their role is and how they infuse this science into their practice. I think we're out of time, so we're gonna thank you so much.